DGO MD in Bombay, DNB, FICOG, FRCOG, a senior consultant, gynecologist, Apollo Multi-Speciality Hospital, Kolkata, Chair, AICC, RCOG, immediate past president, IAGE, Foxy representative to ASFOG, 2021-23, Chair, Organizing Committee, AICOG, 2023, Kolkata, immediate past president, Bengal Obstetric and Gynec Society, Vice President, Foxy, 2017, clinical examiner,
I thank Dr. Umayal, Dr. Chakravarti and the entire box team for the invitation. Now, my topic is thromboprophylaxis in obstetrics. Now, why is thromboprophylaxis important? When we were training around 40 years back, we were told that do not worry, thrombosis doesn't happen in India. Unfortunately, it does happen, but we were so bothered with the deaths from hypertensive disorders, from infections and from bleeding that the odd patient who on the third or fourth post-operative day just walked to the toilet, collapsed and died was too insignificant to be bothered about. We know now that these are the deaths from venous thromboembolism. They are a significant contributor to maternal mortality, and now that in the last 20 years we've brought down our maternal mortality by 85%, and especially because of those three major causes we managed them pretty well. Now is the time that the venous thromboembolism deaths would come out more prominently than earlier. And the best way to do that is, venous thromboembolism has two parts. It has got deep vein thrombosis and it has got pulmonary embolism. It is pulmonary embolism that we are bothered about, and pulmonary embolism, 25% of them are massive and fatal. Irrespective of what we do, we cannot save the patient. So it is much easier to prevent a venous thromboembolism than to treat one. I bring you greetings from Kolkata. Those of you who've been at the AICOG have seen those pictures of the Victoria Memorial and Howrah Bridge. So VTE stands for venous thromboembolism, DVT is deep vein thrombosis, P is pulmonary embolism, anticoagulant therapy, and we can manage this by either low molecular weight heparin or unfractionated heparin. So these are the ones that I'm going to use. So we will talk about anticipating venous thromboembolism, and that is by doing a risk assessment. And we will be talking about how we can prevent a venous thromboembolism, and that is by prophylaxis pharmacological. We will not talk about diagnosis of DVT and PE because that would need much longer time, or the treatment as well. So if we want to set the context, the incidence of venous thromboembolism in pregnancy is about 1 to 2 per 1,000 in the United Kingdom. And P is the major cause of maternal mortality in UK from the direct maternal deaths. At the present moment, indirect deaths are much more common there. In India, there is one paper in obstetrics which shows that the incidence of venous thromboembolism is 1 in 1,500 pregnancy, and that paper came around more than 20 years back from the KEM hospital. But there are papers from the intensive care units across the country in non-pregnant women which show that our incidence of venous thromboembolism is not much less than the West, it is slightly less than the West. What is important is low molecular weight heparin reduces the incidence of VTE by around 60 to 70% in non-pregnant patients. And there is not very good data in pregnancy, but one study seems to indicate that by thromboprophylaxis, we can reduce the incidence by 90% in pregnancy. It can happen in the first trimester as well, but actually the risk increases as the pregnancy advances, and postnatal thromboembolism is 5 times more common than antenatal thromboembolism. So how we prevent that? We need to do an antenatal risk assessment. And the antenatal risk assessment is dynamic, which means that you do a risk assessment at booking, and if anything changes, then you do a re-evaluation. So all women should undergo a documentation of risk factors for thromboembolism in early pregnancy or pre-pregnancy, and this is not possible to be done from memory. Essentially, you need a checkbox which will tell you that what are the things you are looking for. And if the patient is admitted to the hospital or develops any complication, any intercurrent complication, then you need to repeat the risk assessment. And the risk assessment again has to be repeated intrapartum or immediate postpartum. Now, every risk carries a score of 1, 2, 3 or 4, and I will try and simplify it for you. So if the patient has got a previous venous thromboembolism, then that is the biggest risk factor. If that was provoked, which means that that was in the context of the oral contraceptive pill, or a major surgery or immobilization, then you give her a score of 3. If it was a spontaneous venous thromboembolism, you give her a score of 4. If the patient has got a thrombophilia, that could be heritable or that could be acquired like the antiphospholipid syndrome, you give them a risk score of 3 or 1 depending on what kind of thrombophilia it is. For a medical comorbidity, you give them a risk factor of 3. Age more than 35 years, BMI more than 30, parity more than 3, smoking, gross varicose veins or paraplegia, you give them a score of 1 for each of the conditions. What are the obstetric risk factors? Multiple pregnancy, current preeclampsia, caesarean section, prolonged labor of more than 24 hours, PPH of more than 1 liter or any PPH that requires transfusion, stillbirth or preterm birth, mid cavity or rotational operative forceps delivery. All of these carry a score of 1 each except emergency caesarean section, which carries a risk of 2. New onset or transient things that might happen in pregnancy, any surgical procedure except perineal repair in normal delivery, you give a score of 3. Hyperemesis and dehydration, you give a score of 3. OHSS, you give a score of 4. More than 3 days of bed rest in pregnancy, bone fracture, a long distance travel of more than 4 hours, a current systemic infection which requires IV antibiotics or hospital admission. Hopefully I will skip the next one. I think we've got over it, and that is a current COVID infection, or a patient having an ART and IVF. All these get a score of 1. Now these are the heritable and acquired thrombophilias. The heritable ones are antithrombin 3 deficiency, protein C, protein S deficiency, factor V allele mutation, and prothrombin gene mutation, and acquired ones are antiphospholipid antibodies, lupus anticoagulant, anticardiolipid antibodies, and anti-beta-2 glycoprotein antibodies. These are the medical comorbidities which give a score of 3 each, and which are cancer, heart failure, active SLE, inflammatory polyarthropathy, inflammatory bowel disease, nephrotic syndrome, type 1 diabetes, type 2 diabetes with nephropathy, sickle cell disease, and a current IV trials. And this is what should be the tick box, and this is what actually it looks like. Now, I think you're thoroughly confused by this time. What gets a score of 1, 2, 3 or 4? So try and forget what was there and try and remember for the next 3, 4 slides. Now, if the score comes to 4 or more antenatally, then this patient needs a thromboprophylaxis throughout the pregnancy in a prophylactic dose. If the score is 3, then the patient needs thromboprophylaxis in the third trimester, from the third trimester. If the score is 2, the patient needs only postpartum thromboprophylaxis. If the score is more than 2, then the thromboprophylaxis post-delivery should be at least for 10 days. If a patient is admitted to the hospital antenatally, we should always consider thromboprophylaxis. If the patient has a prolonged admission or readmission to the hospital with the postnatal period, then again we should consider thromboprophylaxis. If the score is only 1, then you might not need a pharmacological thromboprophylaxis. So here I have tried to simplify what are the risk scores. Now, previous venous thromboembolism provoked is 3, unprovoked is 4. High risk heritable thrombophilia 3, and which are antithrombin 3 deficiency, protein S and protein C deficiency. All other heritable thrombophilias give us a score of 1. Medical comorbidities 3 each. OHSS in the first trimester 4. Hyperemesis 3. Surgical procedure in pregnancy 3, except perineal tear repair. Emergency caesarean 2. All other risk factors that you can think of give only a score of 1. So if there is any of these, then the patient is basically a high risk candidate. So that is what you need to refer to whenever you are doing a risk assessment. Now, when we talk of thromboprophylaxis, we would like to look at 2 different issues, where a patient has got a previous thromboembolic episode and whether the patient has not got a previous thromboembolic episode. Now, if the patient has got a previous thromboembolic episode, it is expected that the patient would have had a thrombophilia screen. Now, if the patient does not carry a thrombophilic trait and she had a single previous thromboembolic episode which was provoked, like which was related to a major surgery, and she has no other risk factors, then we should give them prophylactic low molecular weight heparin from 28 weeks and up to 6 weeks postnatal. So, previous provoked venous thrombosis without any thrombophilic factor, we give them from 28 weeks till 6 weeks postpartum. If the patient has had a thrombophilia, but the previous spontaneous patient doesn't have a thrombophilia, but the previous thromboembolism was spontaneous, means without a major surgery or without the oral contraceptive pill, then we need to give them prophylactic low molecular weight heparin throughout the pregnancy, as opposed to a provoked thrombotic episode where we give it for 28 weeks. And here also we should give it up to 6 weeks postnatal. Women who carry an antithrombin deficiency, and along with that they also had a previous venous thromboembolism, for them thromboprophylaxis with a prophylactic dose is just not enough. They would need thromboprophylaxis with a higher dose of low molecular weight heparin, which is either 50% or 75% of the prophylactic dose you add, or you give the full treatment dose, which is the double of the prophylactic dose. And you have to give that for entire antenatal period and 6 weeks postpartum, or until the patient resumes oral anticoagulation after delivery, because some of these patients would be on warfarin throughout their life. All other heritable thrombophilias, you give them prophylactic low molecular weight heparin, essentially post-delivery. So they carry a score of 1. So no thrombophilia and single provoked venous thromboembolism, you give them, essentially you give them from 28 weeks a prophylactic dose till 6 weeks. No thrombophilia but previous unprovoked venous thromboembolism, you give them throughout the pregnancy till 6 weeks postpartum. A patient with a previous thrombosis and antithrombin deficiency, you give them higher dose low molecular weight heparin. A patient with a previous venous thromboembolism and any other heritable thrombophilia, you give them a prophylactic low molecular weight heparin throughout the pregnancy. If they haven't had a previous thrombosis, you give them only during the delivery. If the patient has had an antiphospholipid syndrome with a previous venous thromboembolism, then they also need a prophylaxis with a higher dose. Now, how do we decide whether we should give them a dose which is 50% more than the prophylactic dose or 75% of the full treatment dose? This is something we need to discuss with the hematologist or the rheumatologist, and they decide as a multidisciplinary approach. So they should get it till 6 weeks postpartum or until return to oral anticoagulation. We do have patients with essentially antiphospholipid syndrome who are on warfarin all their lives because they have got multiple thrombotic episodes. Antiphospholipid syndrome with a previous venous thromboembolism or arterial thrombosis, as I said, make it a multidisciplinary approach. And a woman with a recurrent venous thromboembolism, we need to always have a multidisciplinary approach. What about asymptomatic heritable thrombophilia? We said that essentially there are 3 high risk ones. What is antithrombin 3 deficiency, protein C deficiency, or a protein S deficiency? So in these women, they should get antenatal prophylaxis along with 6 weeks postpartum. All the other ones are low risk, and if they haven't had a previous essentially a previous thrombolic episode, then we need to see whether they are carrying any other risk factors. If they have only one other risk factors, then just give them postpartum thromboprophylaxis for 10 days. If they have 2 other risk factors, then the score becomes 3, then what we said earlier from 28 weeks. If there are 3 other risk factors, then the score becomes 4, then we need to give them prophylaxis throughout the pregnancy. Now in the first trimester, essentially there are 3 situations which might need thromboprophylaxis. The first one is hyperemesis, where you should give thromboprophylaxis till it is resolved. Second one is OHSS, where you should give prophylaxis in the first trimester. We have a lady who actually had a venous thrombosis in both her pregnancies in the first trimester when she had severe hyperemesis, and we tested her twice and she does not carry any thrombophilic trait. If it's a OHSS, then you need to give them a prophylaxis in the first trimester. If it is an IVF pregnancy with 3 risk factors, you need to give them a prophylaxis in the first trimester. Now, what about labor and delivery in women who are on prophylactic doses of low molecular weight heparin? You need to tell the patient that if she has any pain or bleeding, she should not take her next dose of low molecular weight heparin. If you are considering a regional anesthesia or analgesia, avoid these techniques till 12 hours after the last injection. But if it's a therapeutic dose, it should be 24 hours. If it's a prophylactic dose, 12 hours. Withhold low molecular weight heparin 4 hours after giving a spinal or 4 hours after removing an epidural catheter. Do not remove an epidural catheter within 12 hours of the last dose, which means you have to give a 16-hour break basically. So 12 hours after a dose, and after that 4 hours you do not give another anticoagulant. If you are performing an elective cesarean section, do it in between the doses. Now post-delivery, there will be some patients who are at a higher risk of bleeding, and you might want to avoid giving them a low molecular weight heparin. These patients, what you need to do is a pneumatic, you have to use a pneumatic compression device till such time that you can switch over to a low molecular weight or unfractionated heparin. Now postpartum, these are the patients who need for more than 10 days, those who have a risk score of more than 2. If the BMI is more than 40, if the BMI is more than 40, you need to use weight appropriate doses. In cesarean section, you need to give it for all cesarean sections, except for women who have an elective cesarean section with no other risk factors which require a thromboprophylaxis. Now, what are the agents that we use for thromboprophylaxis? Low molecular weight heparin is preferable. At one point of time, it used to be hugely expensive. Now it has come under DPCO, so it is not that expensive. The dosage is based on weight, and you need to reduce if there is renal impairment for any reason. If you are using a low molecular weight heparin, the biggest advantage is that you do not need to monitor the platelet count. You do not need to do an anti-factor 10A level also, unless somebody who's on therapeutic anticoagulation with a low molecular weight heparin and even then has a thrombosis, then you do an anti-factor 10A level to see whether it is the doses are appropriate or not. Low molecular weight heparin is safe in breastfeeding. If you are using unfractionated heparin for prophylaxis, you use it in a dosage of 5,000 international unit twice a day subcutaneous. Now please remember that there are risks with unfractionated heparin, and the major risk is HIT or heparin-induced thrombocytopenia. Now HIT is of 2 types. One is a type 1 which is idiosyncratic and extremely rare, and one is type 2 which is dose dependent. So ideally you should do a platelet count around 5 to 7 days after you started the unfractionated heparin. There are other options like ganaparoid or fondaparinux in women who are intolerant of heparin compounds. Now this is the prophylactic dose of the low molecular weight heparin. Now most of our patients are between 50 to 90 kilograms, and if you are using enoxaparin, you have to give them 40 milligram, and if you are using dalteparin, you have to give them 5,000 milligram. This is what we need to memorize and know, that for 50 to 90 kilo, it is either enoxaparin 40 or dalteparin 5,000. If it is less than 50, just half the dose. If it is 50 to 90, then you need to increase the dose by 50%. If it is more than 90, consult a hematologist. Do not have to memorize the whole chart. So essentially, this is not visible. Essentially, what you need to know is the first 3 rows and the first 3 columns, essentially. So 40 milligram enoxaparin and 5,000 unit of dalteparin for women who are between 50 to 90. If it is less than 50, then it is 2,500 for dalteparin and 20 for enoxaparin. If it is between 90 to 130, then it is 60 milligram or 7,500. If it's more than 130, always consult a hematologist to decide what would be the weight appropriate dosage. So essentially, please remember that those in whom we are speaking about giving them a higher dose. Now this approximately works out to about 1 milligram per kg of body weight, more or less. Especially in women who are say up to around 1 milligram per kg of body weight or slightly less. What is the therapeutic doses of low molecular weight heparin? The therapeutic dose is either, if you are giving enoxaparin, 1 milligram per kg of body weight twice daily, or 1.5 milligram per kg of body weight once daily. Now, For non-pregnant population, it is 1.5 milligram per kg of body weight once a day is what is given. For pregnant women, it is used to be said that it is better to give 1 milligram per kg of body weight twice daily. Now, since this guideline came out, people audited what people's practices after 5 years and saw that many people were still using the single dose of 1.5, and they showed that the incidence of thrombosis in these patients was no higher. So at the present moment in pregnancy, you can use 1 milligram per kg of body weight twice daily for those who need therapeutic, or 1.5 once a day. The advantage of giving 1 milligram per kg of body weight, that especially in the third trimester, that you get a better window if you suddenly have to plan a labor or delivery. So take home messages is venous thromboembolism is a major complication in pregnancy, and this is something which is going to become more and more important as we should I use the word conquer? As we conquer PPH, hypertensive disorders of pregnancy and sepsis. Proper risk assessment is mandatory, and pharmacological prophylaxis should be used if indicated. And this is something no longer takes, just giving thromboembolic stockings is not good enough. You have to give a pharmacological prophylaxis or give the pneumatic compression device. And this requires your proper a checkbox. This is not possible to keep everything in the head. Thank you very much for your kind attention. I will just end with a quote and from Ian Donald, who said that from individual practice perspective, it is difficult to appreciate the effectiveness of prophylaxis, where failures are more apparent. In addition, bleeding complications are highly visible, not easily forgotten, and frequently attributed inappropriately to the use of prophylaxis. I have seen many senior doctors. He said, okay, I used heparin in this patient, and that patient had a massive hematoma or an intraperitoneal bleed or a rectus-sheath bleed. And then they stop using it. Unfortunately, that is not the point. The point is that this is a life-threatening problem, whereas small amounts of bleeding aren't. Thank you very much.